Sure. So thank you. It looks like some people are freeing up some seats up here in the front rows. So those of you who are looking to come on up, filter in. So we're here to talk about partnerships in healthcare. And most of these faces, I'm guessing, are familiar to those of you in the audience. But we're going to do a quick lightning round of introductions. John, we'll start with you.
I'm the president of Walgreens Health, U.S. Healthcare at Walgreens, a long background in managed care, healthcare technology, and friend of Jenny.
Hi, Walter Jin. I'm the chairman and CEO of Pager. We're in the care navigation, care management, virtual care, and engagement space.
Hi, George Renaudin, president of Medicare, Medicaid at Humana. Been with them since they acquired the Auctioner Health Plan in 2004.
Super. Well, thank you all for joining me on stage. So in our prep call, we decided to do things a little bit differently. We're here to discuss how to build, buy, and partner within the healthcare ecosystem. But we decided to agree upon some two key fundamental ideas. The first is that partnerships are crucial. So there's that. We're going to start with that premise. And the second is that we're all on this journey together to improve the lives of the end person, the end patient. So with that framing for reference, I'd like you to give us an example from your executive viewpoint of how you think about build, buy, partner for the end user. I'm actually going to start, I think, with this one with you, John. You talk a lot about your mom and how you think about your mom as the person whom you're serving. And so as you build, buy, partner within the ecosystem, can you give us an example of how you frame and structure that?
Well, I think that my mom's 90 years old. She has a couple of chronic conditions. She has multiple specialists. And she's a great example of we make healthcare way too hard. We've got all of these resources pouring into healthcare, but it would make it really hard for the end user. So when I think about what we're trying to do, for example, in primary care with Village, by co-locating Village MDs or our primary care, our investments in primary care at stores and optimizing the experience of even walking in and meeting the office staff, everything has to be oriented towards a patient that has very little time and is going there for the whole healthcare thing is inconvenient. They need to get in and out. It's transactional. Or my mom, who's got multiple chronic conditions. The care is complicated, but her life, even at 90, is pretty busy and pretty complicated. And everything from the office layout to how we inform the docs to how we connect her doctors and her pharmacists in an ideal world is designed to make her life easier and to provide her the care, the information, and the access sooner than to take her out of the decision loop of having to fight for figuring it out or getting access to the care she needs.
So as you're thinking through that ecosystem, then the decision on whom or what to partner with is really focused on the end user 100% of the time?
It really is, because if we don't have that values match, I mean, if you look at, I think one of the reasons why retail and healthcare have not succeeded historically is I don't think they share the same values alignment. And I think for our perspective, we'll have contracts with everyone because we're Walgreens and we need to be connected to everyone from a pharmacy perspective. But we are focusing on health plan partnerships, technology partnerships where they share the same values, because it helps inform how you actually design the user experience, whether it's in 340B in our Shield Specialty Pharmacy Services business. If we're working with a health plan, a PBM, or a health system that isn't as focused on adherence as we are in the complicated patient experience for specialty drugs, it's just not going to work. And our ability to actually drive, chart-topping adherence numbers, lower total cost of care starts with, do you share those values? Do you understand how hard it is for someone with a complex condition who's trying to access their specialty meds in and around an academic medical center or regional hospital, how hard that work is, how hard that life is, and then how do we make our work make their life easier to drive a better patient outcome? And no, I think it's really pretty critical.
That's great. George, in our prep call, you talked some around the efficiencies of cutting down administrative burden. And you talked a little bit about where you live in your home, right? You live in a horse farm in your community. Can you maybe talk about how you thought through the partnerships around decreasing administrative burden and the direct impact that people in your community, or maybe even on your horse farm, might feel that benefit?
I think the horse farm is going to be a hard stretch. So I'm not going to try to make that connection. But, it's interesting. I had my annual checkup yesterday, and my PCP works for a fairly large group here, but very close to my home. And when he found out who I worked for, he went on this very long story about how administrative burdens get in the way. And he was talking about how it was my first time with him. My PCP retired last year, the traitor. And I really miss him. But anyway, so it was my first visit with him. And so it was about an hour and 15 minutes that we were talking. And he was the whole time furiously typing in. And as we were having this discussion, he said, I'm also then, after doing this, I'm going to have to go tonight back in and rekey all this into Allscripts in the way that it wants me to have it format-wise. And as he was talking to me, we started talking about interoperability quite a bit. And I said, this is a big focus of ours and where we've partnered. In 2019, for example, we came together with Epic and formed a partnership to figure out something new called Epic Payer Platform now that we use. And it was really about trying to make sure that when the clinicians, such as my primary care doctor yesterday, was interacting, that things get served up in a way that brings in information that the primary care doesn't always have, right? Especially if you're dealing with patients with multiple chronic conditions or seeing multiple specialists, probably getting scripts filled all over the place. And being able to...
I hope not.
Well, I hope not either. I hope it's all at Cinnamon Pharmacy. Anyway, and the idea of bringing all that together to improve patient outcomes, improve the interaction with the patient in a way that allows the clinician to really think about how to interact with the patient rather than, am I putting this information into the right cells in this particular format, really makes a big difference. And what we're seeing through that platform, and we're now connected with almost all the major EMRs now, it's amazing what we're able to accomplish. The Oxford system, which I said I came from, was one of our beta sites. More than 50% of their authorizations are being done without a single human intervention, just going straight through the system.
Wow.
Because of the prior auth logic we're able to put into this. Their medical adherence rates have zoomed because they're seeing not just what they are prescribing, when their patients go to the Louisiana Children's Medical Center instead of to Ochsner, that record's being pulled in. So they're able to see all that, which is really allowing them to do more patient-centered care. From our standpoint, it's that kind of partnership that allows us to stay ahead of the pack, for example, in our STARS ratings. And 6 years in a row now we've stayed ahead. And one of the reasons for that is interoperability. It's the connection and the partnership, because we're partnering, as I said, with Epic, but with ECW and Allscripts, name a system. And so that is really important in how it translates to the care for the patient in a way that's very different and improves outcomes, improves our STAR scores. It's all really connected, and that's where we're focusing a lot of our attention on how to partner.
That's great. Walter, your brother is an ER doc. And you've spoken a little bit around pager in some ways. I'm going to paraphrase so you can correct this, is giving all people or many other people access to kind of a brother who's an ER doc.
Yeah, my brother's a ER doc at Kaiser. Next to John, he's the smartest guy I know in my life. And I've had the distinct pleasure of having a doctor in the family. And, when our parents were sick, my mother had cancer, my father had respiratory issues, and it was just great to have a doctor in the family. Anytime any question came up, my brother was there. We grew up in Southern California to help him along that care journey. I just dawned on me as we went through that care journey and thinking about how pager could help in the system. The amount of time that my brother acted as a physician during my parents' care journey was actually very small. And if you know everything about some of these chronic diseases or life-ending diseases, that there's so much, talk about, George, administrative burden. There's so many things that patients have to do. All the burden comes back on the patient in terms of coordinating care, navigating care, understanding after you go through the pharmacy window, what did they just say? And when you come back home, I don't know if I eat with or without food. So many questions come up, and having that resource there to navigate, coordinate, interpret things for you. My brother really wasn't acting as an emergency medicine physician. And he was at Kaiser, so it's an integrated model. But the unfortunate reality is that most of the markets, almost all the markets, are not designed that way. Payers and providers and pharmacy are all separate organizations. And so when you think about how to achieve that experience, you can do it one of two ways. You could increase the number of physicians that exist in the country so that we don't have this mismatch where primary care and physician labor from a supply chain perspective is in such short demand, and they're obviously overworked and overburdened. So we can try to fix the supply chain problem. The other way to do it, though, is to create more efficiency in the system and create connectivity through partnerships so payers, providers, and pharmacy can all work together in an integrated fashion so that you don't have duplication of resources and efforts, and there's a lot more efficiency and productivity can come out of that coordination of care. And so what we try to do is create what I call two concepts, a stitcher and a wrapper, for lack of a better word, where we could stitch together the experience so that the consumer doesn't get bounced around the system. That's where the waste comes in, or by either doing too much of one thing in terms of overutilization or too few because they're so confused they end up not doing anything until things get worse and they do have to go to emergency room. And I think that the other part is wraparound services. We could wrap around services that are easily accessible so that at the point of need, they can get the care that they need immediately. Because if you don't get them at the point of need, then I think bad things happen along the way, that journey.
Yeah. Well, I as a physician, right, I do a lot of wrapping and stitching for family members, for not literally stitching, but stitching across their healthcare. So I think the service is a great one to help people navigate.
Can we ask you about how are you thinking about it from a Homeward perspective?
Yeah, from a partnership. So Homeward is focused on healthcare delivery in rural healthcare markets, and it cannot exist without partnership. And so it's not a competition model. It's what is in existence, where is the trust, and how can we play a role in both enabling providers to take better care, engage in risk-based contracts, and payers help manage. So we sit in between, where we actually look at and take on county level attribution on behalf of the payers and enable the providers to transition and underwrite them in their value-based care contracting at the county level across populations. So we're not focused on risk coding in Medicare or delivering certain services in Medicaid. We're really looking at the county level, because I think, similar to what you all said, we believe healthcare is very local, and that it's only through partnerships within a geographic constraint that you can really make inroads.
That's cool.
So George and John, you have both talked about being some of your partnerships being payer agnostic, which is interesting, coming from Walgreens and Humana. And can you talk a little bit around how you think about that and how you approach that and what that means?
You want to take that?
Yeah, I'm happy to start. So, we now, with our Centerwell segment, we're both payer and provider agnostic. And really what we look for is, what are the key parts of what is integrated senior care? That's really what we're focused on. If you just boil our strategy down, it's about integrated senior care. And so when you think about that from our standpoint, from the health plan standpoint, what we care about is how we can work better with providers to focus on the seniors' needs and wrap them around services that help them to care for the whole person. So that's from the health plan standpoint and what we're looking for, and why we look for providers who are successful at taking care of people with great health outcomes. We have a unit that works with me we call the Alliance team. And what they do is they find really well-performing primary care doctors and then help them expand to other geographies to bring those positive services elsewhere. Some of those have been pretty well known now. Oak Street, Iora, the Chens, those are people that practices that we saw successful in certain places, and then help them expand to other markets. And so we continue to do that, and that's really around this idea of being, although we own our own primary care entity, being agnostic and wanting to just improve the outcomes for our members. Similarly, when you think about our CenterWell, which is our primary care organization, the home organization, and the pharmacy, it's also about how can we deliver a seamless experience across and something differentiated to improve the quality and outcomes. And so that's really what we're focused on, why we've gotten into that, because unfortunately there aren't enough integrated senior-focused entities across this country. There just aren't. And when you think about the shortages in physicians, when you think about the expansion that's continuing to have when our country has more and more Medicare beneficiaries, that focus is really necessary. And unfortunately, we don't see enough focus there. There's still too much 15-minute, 10-minute, sometimes 8-minute visits. And for a senior, that's not good care.
Yeah.
And so that's the reason why we focus as we do on an agnostic solution.
That's great. Yeah, too much to cover for the seniors, where 70% of them have 3+ chronic conditions. That's in right. 8 minutes. Yeah, it's a lot.
I think that, I think George is motivated by the same thing that motivates us. We think that healthcare is a team sport that's frequently undermined by individual incentives. And, our view at Walgreens is, how do we be the independent partner of choice, which, by the way, is not just payer agnostic, it's really payer added value, because each payer, particularly as you break it into micro markets, has different needs. I mean, not every payer has the stars performance that George's plan does. So we will help payers work with that with our pharmacists in the stores. In other cases, we're literally the 40% of our stores are in medically underserved areas. There's not enough docs. Those are places where we're going to start to add more services, having pharmacists provide some of those services. In the UK, we've actually got about 120 different services now that the NHS, would previously be thought of as primary care, because England's got the same problem. You don't have enough primary care doctors being created for the population's needs. And we're testing out a whole series of services, and we're rebuilding the way pharmacies, the way the supply chain works, to allow pharmacists, particularly in those areas of high need, to provide not just the connection information in pharmacy, but some of the basic healthcare services, some of the evaluations that we think will be added value. But it's not just, we are definitely payer agnostic, because we'll have contracts with everybody, but it's really thinking through, how do we become an added value partner? And it really does vary by partner, by business line, but it's a way of doing work that has not been the way Walgreens, CVS, the traditional retail pharmacy was looking to add transactional relationships with health plans and providers. We're going to our 2,000 hospital partners, our hundreds of payer partners, and saying, what do you need in this particular geography in order to solve a problem? I was talking to a payer last night about a particular series of geographies in the South where they have a very specific problem that our stores can help solve. That would be different for a provider in the Northeast, and we have to also look at all lines of business. But it's really trying to help health plans and health systems solve the problems they see around delivering better patient outcomes.
Yeah. I love the phrase, healthcare is a team sport with individual incentives, which feels like when I'm coaching my 10-year-old son's basketball team. That's very much feels
Pass.
Like. Yeah. Pass. Don't just shoot. Yeah. Walter, you and Pager get to contract with both the payer and health systems. You see both sides of that. Can you talk about what that is? And this is similar to Homeward, but you're sitting in that interstitium. Yeah. And what is that experience?
Yeah, we really kind of believe from an agnostic point of view that we don't want to be the digital front door, because who's Pager? Who are really any of the tech point solutions out there? They, for whatever reason, as technology went through this wave and mobile and digital adoption over the past 10 plus years, especially pre-COVID and during COVID, I don't understand why startups want to be the front door and have their own brand. When in healthcare, the brands are already established. It's a big payer, big provider, big pharmacy in your local market basis. And so we don't really subscribe to try to create another digital front door. I think there are enough out there. what we'd like to do is enable the front doors that already exist. So the key in partnership is the interconnectivity of what happens whichever front door the consumer decides to come in. So if they want to come in through to the provider, fantastic. If they want to come through the payer, fantastic. But when you start stitching or mapping out that journey that they're going to take, they're going to start to engage with pharmacy, with provider, with the payer side at some point and multiple points in that journey. And so what we try to focus on is how to create that stitcher interconnectivity so that the journey gets connected, and it should be seamless to the member. So, member meaning consumer or employer or provider. So when they come to that door, they may start their journey around, let's say, on the hospital side through Epic or whatever mobile app that they have, MyChart, and they're looking to get care. But along that journey, they're probably going to need to understand benefits and pick up a script and things of that nature. So how do you connect the dots so that they can have a seamless interaction, so that they may talk to a physician in a local hospital and then get connected quickly to pharmacy once that script gets issued. And then when they're back at the home, maybe they need services from Homeward because they live in a rural setting. And then they need to understand, what's this EOB I got in the mail, and have customer service from the plan engage with them. And instead of going through 5 digital front doors, which I just explained there, they can go through the one of their choice and then get connected to get all the answers, all their questions answered through that experience. So that's kind of why our utilization engagement is so high, because they may come through one entry point, but they consume and interact with 5 different people that don't work for the same company.
Yeah. I'm curious to hear, George, your perspective on solutions that come in and contract with both payers and providers, because a lot of the work that you do with provider networking and provider contracting is directly with the providers. Is that seen as helpful? Is it seen as a threat? How do you think about that?
Does it depends count as an answer?
It can. Yeah.
So, it really does. It depends upon what new capability it's bringing. We're looking for capabilities that help to reduce the administrative burden and smooth that workflow between the payer and the provider, and because that's very important for us. It is something that we see as vital and critical to the way we do our work, because we are predominantly a Medicare and growing Medicaid plan. Right? We don't have a lot of commercial. We're actually withdrawing from the commercial market. So when you think about that, if we're going to be able to provide solutions to our members, we need to do it in a way that is going to be in that provider's workflow. And so, over 25 years ago, Florida Blue and Humana founded Availity with the same kind of thinking. The work we did with Epic that I mentioned is really about, how do we get in that workflow? Because we don't have, and I would argue that almost none of the payers anymore have the ability to say, no, you have to use my front door is the only way you're going to get in. No. That's just not realistic. And it's not really going to solve the administrative burden in the system. And so therefore, we have to have that connectivity. We have to have those partnerships. And it's something that we believe very strongly. If you're going to help improve the system, you need to figure out how to improve the workflow across it. And that's why, for example, we have now connectivity with 600,000 providers across the country, 800 hospital systems across the country. We'll have, I think, 200 million records that will come through electronically now. And that's all because we're leveraging all the different connection points and the partnerships to get in that workflow to decrease the burden and improve the outcomes for our members.
Yeah. John, how do you think about front door to healthcare? We've had a lot of conversations.
Front door. I mean, we got tens of millions of people walking through our front door every day. I mean, I think what we want to do is leverage the connection, trust, and information. We have connection, trust, contact, and information with payers like George, so that because we have the gift of an opportunity of 12 plus million people growing very quickly, individuals every month on our website. We've got hundreds of millions of people looking to find care through our digital tools, which I think are sort of last gen versus next gen, but we're going to change that. How do we take all of those many points of connection in a disconnected healthcare system and help the doctors, health plans, specialists, social determinant like vendors like food, connect and understand what the next need or the current need of that patient is, so that that problem is getting solved even before the patient and their family have to figure it out from scratch. So we really we don't think we've taken advantage of all of that connection, packaged it in an information and actionable way, and provided it to the other partners in the health system. But we think that is our duty, and it will allow us to be, again, a better partner and kind of drive a better patient outcome, whether it is around a specific initiative of ours or not. If we can show that delivers a better patient outcome, we're going to have a rationale for Walgreens to be a much more added value partner, and that's the goal for patients and docs.
Yeah, it strikes me that we're talking a lot about, in a good way, partnerships for system connectivity throughout. And we still have that last mile of healthcare delivery to the member, to the patient, right? And so both are working in parallel, but they're kind of adjacent solutions, right? And so as we think through, again, where we started, which is we're all in this to make healthcare better for your mom, for your family, for not your horses, but your horse trainer on the farm, right? So how do we bring that together? So I'm curious, as you think about, you've all described bits and pieces of what your organizations do today in partnering throughout the ecosystem. What do you think, throw the ball out a little bit further, like what do you think are going to be the major partnerships that are going to help us collectively as a healthcare ecosystem through partnership achieve the goal of delivering better healthcare? What do you think that is for your organization or writ large for the industry?
Walter?
I was going to say, you guys can use jump ball right
ball?
here. Yeah.
I think that there's a lot. We talked to Jenny. You talked about the alignment North Star of partnerships that we all agree that one of those fundamental principles is that the consumer's in the middle. We all care about. So when you start there, I think the differences between payer, provider, et cetera, are a lot smaller than people think, because people talk about engagement, access, satisfaction, the experience, better outcomes. So the quadruple aim seems to be the same language that everyone's talking about. The only variable that I think is different is the cost equation, the lower costs. Because on fee-for-service versus value-based care, I think their objectives are somewhat misguided, where the system financially isn't incented the right way. So you talk about jump ball, I'm very interested in what value-based care can be. I think we went through a first phase one where we put in financial incentives for providers to take risk. But I've seen this movie before. We've all seen this movie before. This concept of risk and providers have been around for decades. And it doesn't work without providing the right infrastructure and tools for them to be enabled in that setting. And so I think about a world where when you think about partnerships, since we're in baseball season, or it just ended with the World Series last night. I think about on first base having primary care attributed to a certain population of folks. Second base, I think, is community-based care. So something like Walgreens. What is it, John? This is a Walgreens within 5 miles of 7% of America.
Americans, yeah.
And that's incredible from community-based care. And I've been in a Walgreens. Not just a Walgreens, everyone's been a Walgreens, but the actual health corners that you have. And I remember talking to an advisor, and I saw a patient at the pharmacy window come over and say hello to the health advisor because they knew him in the community. So that boots on the ground engagement that Walgreens offers in all the communities is such an advantage from an engagement standpoint. And then when you layer on top of that services like Pager, which provide virtual care, 50-state nationwide service, 24/7, on-demand access to nurses, doctors, coaches, care coordinators, et cetera. And then you add that fourth layer, which I'll bring it back home to the last mile, like Homeward, the last mile into the home. I can't think of a system where the consumer's in the middle and they have surrounded by, obviously, the payer because of all the finances, but primary care, community-based care, virtual care, and home care last mile. That to me is an ecosystem if it's all coordinated in a great way, can achieve that triple quadruple aim, but it can only be done through partnerships. That gets me very excited to go into that next phase of value-based care that actually works to provide that stitcher layer and wraparound services, all working in a coordinated fashion for the benefit of the consumer in the middle. I'm excited to work towards that goal.
Yeah, I know you don't want us to talk about AI, right?
Well, it's coming. It's coming.
But I think that technology has sold us in healthcare, but not saved us. And yet I'm really excited about what we're doing. Everything from automated pharmacy and distribution and supply chain, we've now got away, and we've got 11 major distribution centers, and we're automating the way that a lot of mail order pharmacies have worked that we built at Medco, that CenterWell has built, and providing that same level of automation, simplicity, and order as in a packaged, consistent way for everything from a Walgreens, 40% of Walgreens stores to Publix to Amazon, and open up the pharmacist to actually do more stuff. I think I'm really excited about how much more my mother with multiple chronic conditions, or my nephew Lucas, who's got cystic fibrosis, how his family can access, and my family can be able to access better information, more intelligent tools. I think simplifying the back office of doctors. I really am very excited about this next generation, not just of generative AI, of how technology is solving simple administrative solutions to open up more time for humans to connect with humans, because ultimately the last mile is really about the last moment when someone with a problem is talking to someone with a heart who's got a solution. And I think the only way we solve for the George's problem of not enough providers being created, and we aren't graduating enough pharmacists, nurses, and doctors, is to leverage technology in a new way, not to replace humans, but to allow heart-centered beings that we need more of for our vulnerable, chronically ill, the time to do the important work and not be hammering along on a keyboard. I do think we're at the cusp of something really special there, and that's as you throw the ball out downfield. That's what we're spending a lot of time thinking about.
George.
So, it's interesting. A lot of the connection here that we're talking about, in what I said earlier about interoperability, one of the issues in the way is the complexity and the cost of getting a lot of the connections done that I think we all need. And, I was thinking about a friend of mine who works at Nashville Business Machines was telling me that, if it wasn't for healthcare, he doesn't think he'd sell a single fax machine. And it's a sad statement when you think about it, that it's really healthcare that still uses a lot of faxes. One of the reasons for that is because of the cost and the complexity of connecting. There's FHIR APIs and other ways, but it actually is pretty complex to make it work, and you have to set up things correctly. So one of the things that, as you asked, what's in the future, is I'm hoping that digital brings to us, and the future capabilities bring to us the same capabilities to connect as easily as we do to an Uber or to a Lyft, is to connect to a doctor or anything else in the future, where it's so easy, it's almost something that you have to work to avoid. Today, you have to work to get the connection.
Yeah.
So that's something that I think really can help us in the future. And you talked about producing enough clinicians, John, and the ability to leverage clinicians' time where they're not spending, like mine talked about yesterday, an hour of his evening retyping things in. I think digital is going to make a big difference there, and it'll extend capabilities using telemedicine and other capabilities that makes it as convenient for us as the platform is that we carry around in our pockets every day. And so that's a big focus. One other thing that we're really thinking a lot about, and if you're familiar with the Medicare Advantage marketplace, you've seen an explosion of all sorts of not directly medical benefits. A lot of things that help with social determinants of health. We have cards, for example, now that pay rent and utilities and food and transportation, all those kind of things. And I think that in the spirit of partnership, one of the things we need to work on with those partners is how do we show the improvement in health outcomes directly related to some of those. We intuitively think that it can help. Adams at Kaiser, I remember having lunch with him one time, and he said that for their Medicaid patients, they'll pay the rent if it means keeping their patient member with diabetes, with their drugs that they need. And so it intuitively makes sense that some of these things are health related, especially when you think about the focus on social determinants of health, but really coming out with being able to prove it. And I think that that's going to take further advancements in, I know we're going to talk about it next, but in AI and other methods of being able to really see in the data and the analytics to prove that what we're spending dollars on really is going to move the needle in health outcomes.
So that we make the right investments for the population.
Exactly.
Yeah. I'm going to riff a little bit off what John said, and we only have 2 minutes. I'm keeping my eye on the clock right there. Which is, I am making a very big bet on technology and AI to scale services where services don't exist, particularly in rural, right? And I do think we're at a moment in history that we can transform healthcare delivery and democratize healthcare services to make it efficient to deliver to all people. And you can't end a conference without hitting one X in the bingo card, right? And so the question is, in terms of generative AI, how do each of you think about build by partner as you look at the ecosystem and the solutions you're bringing to market? Maybe we'll start with Walter, George, and then John, since you had a little touch on that earlier.
Well, real quick, all three is how we look at Gen AI, build, partner, and buy. We're built on GCP, Google Cloud Platform, use their Vertex AI engine. I mean, we're not going to natively create our own Gen AI, platform. It's Microsoft and Google obviously are the leaders over there. But we do already build product to George's point about speed and administrative burden and efficiency. We're using that internally for our own engineers, for AI co-pilots. We're using it with Emids. I know also has Gen AI capabilities. And then it surfaces in our product for enterprise users to be able to do their work faster. So to me, it's about speed and efficiency and velocity and increasing that.
It's interesting, Walter, that you made that comment about speed, because one of the ways we're using right now, we're nascent. I mean, let's just face it, it's really early. One of the things I do worry about is making sure we have the proper controls in place and the peer review of what's coming out to, make sure that the right answer is coming out the other end. But, we're doing it to get our teammates up to speed more quickly. Medicare Advantage is a cycle, right, where there's a certain sales period, and then time's up, I guess. So that we're using generative AI to help our members, our associates help the members get the answers more quickly, because we'll ramp up a large team around annual enrollment, and then that team will ease down. Well, generative AI is helping them get up to speed more quickly so they can answer all the questions being asked and not have to transfer people from one place to another. We're doing it in health services the same way. And so I think that that's really the early days, but we're certainly looking to do a lot more.
John, last word.
I think the most important thing is to make sure that all of us as healthcare companies hire enough talent internally to be able to partner, build, or just get out of the way. Because I think that the basic competence in these tools, the tools are so powerful, to George's point. I was in a discussion with a primary data scientist who's a doctor at an academic medical center who is very sick. He's got a very rare form of cancer. He is using ChatGPT and the hallucinations to help inform his care of Memorial Sloan Kettering. It's just amazing.
It's amazing.
But he is also an incredibly wise, because he's got a comp sci degree and an MD, a guide for his own care, and has some of those borders, kind of understands what the borderline conditions are, where you decide a hallucination is worth pursuing versus not. So I think we're in the cusp of something big. I think what's really important for healthcare is that, unlike in most situations, that we actually hire talent that's not native to our institutions. And the exact same thing is happening in areas like national security, where they're having to jump ahead and hire new novel expertise that can inform the national security decisions. I think we have to do exactly the same thing in healthcare. I think that's going to be a challenge.
Yeah, that's a great way to end. I want to thank you, John, Walter, George. Thanks for the panel. Thanks for the discussion.